right, come on up, Dr. Ollila. So, Dr. Ollila has started here many years ago. His hair was not as gray as it is now. He's gone through many years of melanoma, and he's going to give his rendition of where he started to where we are now, right?
I am.
Okay.
Thanks, Trish. Thanks, Paula. So I am not sure why I always agree to talk after the patients. I'm not sure Paula does that to me to make sure she's respectful of my day or what, but I just want to acknowledge the work that Paul Landman and Trish Long do for this every single year because it's incredible. Can you join me in So they kind of play Mutt and Jeff on this one. One says, oh, she does all the work, and the other one says, oh, she does most of the work. But I think it's a really unique pairing of the two women that we actually have at our disposal for the entire program. And so I just want everyone to realize that whatever I'm about to say, there's got to be a team with us. And that, I hope, is the theme you've heard all day. Yes, I'm old. I'm 61 years old. And for those of you that may or may not realize, there have been some incredible ups and downs in the care of the melanoma patient. And I'm just going to walk you through my personal journey, okay? Because I think this cartoon depicts it the best. You'll see some things where I've actually written to counteract what I said previously in manuscripts. And that's the way that this field goes. You've already heard some tips. You saw in a tumor board of what some of my punchlines are going to be. You don't realize it, but there's not one, but two TILS patients have been meandering through the conference today, which is the most exciting thing that we're doing. And so there's lots of things, but I think the context of where we were and how we've gotten here is really important for people. So I was a resident from 1990 to 1995, and Ms. Long, I do not need to hear what grade you were in at that point in life. I know. Mrs. Edmondson, please make sure your phone goes off while I'm talking. I cannot wait for that. Yeah, I want it. I just want it to go off, okay? So here's the interesting thing. For all of you, I took care of one melanoma patient as a resident. I took care of it with that man, Dr. Kim Hamelberg. It was on the left upper back. It was a Clark level 4. We did 2 centimeter margin excision. I said, now what are we going to do for the patient? And he looked at me like, nothing. We have no FDA approved drug that actually works. We have nothing to give. And you see, if you pull out one of my archaic textbooks off of my shelves, median survival for a stage 4 metastatic melanoma patient, 6 to 8 months. That's it. Okay? So I go to clearly a hotbed of melanoma. I trained under Dr. Don Morton. For anyone who's been on Dr. Google, you'll see his name over and over and over. And unfortunately, he was the king of sentinel node, which is great, but also the king of failed immunotherapy after immunotherapy after immunotherapy trial. So we all have to remember that we're benefiting on the backs of the brave patients that went on to clinical trials back in the 70s, the 80s, the 90s, when we didn't have anything. Nothing passed muster. Did I learn how to do the sentinel node with Don Morton? Absolutely. Is he the godfather and the pioneer of sentinel node? Absolutely. Does Rami and his group look at sentinel nodes exhaustively? Absolutely. That's where it starts. But still, as I told you, we didn't have any other therapy. So we're diagnosing people more accurately because we have a sentinel node and we can tell the stage, but we don't have anything for them to go on. We used to pluck out the sentinel node. Rami or one of his team would say, oh, you have micrometastatic disease in the sentinel node. We'd take the patient back to the operating room for a complete lymph node dissection. Remove all the lymph nodes in the neck, remove all the lymph nodes in the armpit, remove all the lymph nodes in the groin or whatever the basin was. But guess what? We were wrong. Doing the completion lymph node dissection for those patients that don't have demonstrated micrometastatic disease remaining have no survival benefit. So for those of you that wonder why Trish or why Paula keep bringing you back for every 3-month ultrasounds, in addition to all those PET scans, it's because we have an international trial, the US and Australia, and we have a second German trial that shows that ultrasound surveillance of the basin, as opposed to immediate surgery, has identical outcomes. Right? So that's why you're going to see, and people struggle sometimes to say, well, wait, I'm getting a PET scan. PET scans are good to about 5 to 6 millimeters. Lauren Burke and her team with the ultrasound can find a thickening of a cortex, can find loss of fatty hyaline. And I'm just giving you buzzwords that you may see in my chart, because remember, Trish, Paula, Brent, Rami, we don't control when it goes to your my chart. We can't. We're forbidden from stopping anything. So there's lots of things, but that ultrasound probe is much more specific when it's targeted to an area. And that's why we can save the patients having to go through those much bigger operations if there's nothing there. But here's the game changer, right? And this is absolutely, positively what's changed our world. So for those of you that come in and talk to me, I specifically ask you not to read anything prior to 2011. I then ask, please really don't read anything prior to about 12 to 18 months from the time you see us, because that's how fast our field has changed. From 2011 to 2025, this has been an absolute positive whirlwind. These are the people we see. These are the people we saw back in the 90s when I started fellowship. These are the people that we still see today. And so for some of you in this audience, you may be going, hey, denial is incredibly powerful. And don't let anyone tell you anything different. The number of exotic headdresses, bandages, hide it type garments we've seen, it's amazing what the human being can do to deny, okay? All these people had either locally advanced stage 4 disease. The gentleman in the upper left, actually, those are distant nodules from a stage 4 disease. So again, here's the history for you. This is not sugarcoating how poor this was. Dacarbazine, FDA-approved drug based on feeling. There's no level 1 evidence that dacarbazine has any overall survival benefit. It has a response rate, but no, so anyone who took DTIC or knows anything, interleukin-2 has a small complete response rate. Interferon alpha-2b was like sugar water. You gave it to the patients, they felt miserable, but there's no overall survival advantage. Again, context and rooting us on the ground of why we're here in this era of what we are for the last 14 years. They used to say, if the surgeon and the dermatologist can't cut it out, send the patient to Dr. Hanks. Hopefully he has a trial you can go on. But there was no prospective randomized trial that showed a benefit. So a lot of times patients would come to me or my colleagues and we are doing some major multi-organ resections, multi-basin resections, because we didn't have anything else. Okay? And you heard from Kristen how that has flipped, and I'm going to give it to you again. But I've written many things about complete metastasectomies. And then the world spins, and we continue to say, wait a second, maybe that's not the right thing to do these big, major operations when we're starting now in 2011 and 2012 to start accumulating effective agents. We've talked about it, we danced around it, but the checkpoint inhibitors are what makes a lot of this go round, right? And you heard earlier about IPI, right? IPI blocks the CTLA-4 inhibitor. So, right, I always think of this as a brake on the brake. So that means these cells just proliferate. The PD-1, the Pembro and the Nivo antibody here, this then allows the white cell to recognize the tumor cell and kill it, okay? If you had any cartoon that you wanted on your phone, that's the one. Because this is what's the story of how we got our beginnings of being able to advance. Here's the basic trial, and I don't know if Brent was there. This was presented at ASCO, which is a huge meeting of all oncology, dominated by medical oncologists, surgical oncologists go, radiation oncologists. It was a standing room only presentation to see a survival benefit of 4 months. Think about that. A survival benefit going from what I've showed you previously, right? That my archaic textbooks, 6 months, same thing. Heavily pretreated patients, and this starts everything. Okay. Fast forward now we have, I've talked to you, you've heard about IPI, you've heard about Nivo. This is a slightly outdated slide because now the overall survival at 7.5 years is 48%. But this bottom curve in treatment-naive patients, meaning they haven't received any treatment, is the IPI. The blue line is the PD-1 inhibitor, or Nivo in this case. This is the combo. So we now know that combo is superior, as Dr. Hanks was saying. Combo is superior in efficacy, provided we can get the patients through, right? So you still have a delta between these two curves, so you have to now weigh the risk-benefit of being able to get the patient through. Again, these are for stage 4 patients, treatment naive, but Checkmate 067 is just a game changer. So now what do we do? Now we have the surgeons wondering, what the heck do I do now? I got this patient with bulky disease. I got a lot of things going on. What do I do? Surgeons are so used at this time to doing these big operations. You don't have to raise your hand in here, but several of you have had major operations prior to the immunotherapy era. And trying then to re-educate people of, oh yeah, that's what I said then. Wait, this is what we're going to do now. It's a completely different mindset. So the concept now is, and this is just a basic schema of neoadjuvant, right? You have a patient who has stage 3 disease, and instead of the surgeon taking the patient to the OR, we lead with whatever drug therapy you want, right? SWOG 1801 had a single agent, Nadina has dual agent, how many cycles, how many weeks you wait, we can still discuss that a little bit. Well, you're gonna go to your surgery. And now we have a really powerful pathologic specimen from Rami. What's in or not in, or how little or how much is in that surgical specimen means a ton. And again, we've talked about these, and these are the backbones for what we do. Single agent, PD-1 inhibitor, dual agents, intralesional TVEC, who we've talked about previously, and these all have event-free survival that is going to lead to an overall survival. But the trials are just not mature enough to have an overall survival benefit unless Brent has inside information and he knows that one of them is going to be published. But event-free survival has been published. We're still waiting on overall survival benefit. Okay? These are the game changers. These are the ones that make some of you in the room go, David, that's not what you said 10 years ago. And I know I didn't. That's why this is the roller coaster talk. Because this is a complete flip. This is coming in and saying, okay, we got options. Let's go through the options. If any of you have read my notes about you, I say you're going to go see Dr. Hanks. I've discussed all 3 of these options. He's going to talk you through which one he thinks is the best for you, and then I'll see you back. Then we'll talk about a surgery, and hopefully the magnitude of the surgery is much smaller. Okay? Now what? Not everyone beats it with these drugs. You can make a great argument, or you should have put your hand up and said, David, what are you and Brent doing about these 51%? That's an entirely fair question, right? Immunotherapy resistance is an extremely hot topic, and it's a focus of what Brent's lab is looking at, trying to figure out pathways, markers, signals that can say to us, you better be worried. Okay? So I know you've heard a little bit about it. Now, there was one step that wasn't told to you guys. At some point, I got to harvest tumor, right? I got to harvest tumor in a sterile fashion, roughly 4 by 4 centimeters, put it into the magic potion from the company, because we're not allowed to know what's in the potion, send it to them. Hopefully we get the email that says the cells grew, patient comes back, lymphodepleted, give back the cells. And that's the first time I've heard how cold they are, so thank you for telling me that. Okay? This is the new, right? And so if you'll notice, a lot of what I've said is about our program, and I really haven't said anything about any other facility in North Carolina or South Carolina. She was patient 1 in North Carolina and South Carolina. Yep. So you think of all the other facilities in North Carolina and South Carolina, we were the first. And I'll just leave it at that, okay? This is the exciting thing. This is really exciting. So we actually have hope for the immunotherapy resistant patients even before talking about a clinical trial. They could go on a clinical trial, but we can still harvest tumor, send it to the company, hopefully they grow so that we can infuse it back into the patients, okay? So again, this is always a great day for me. I am not upset that I'm the last speaker. It does not bother me at all. So once again, thank you guys so much, and I hope that that talk gives you context of the journey of where I've been for the last 26 and a half years, because the patients have gone through this journey with me. So thank you very much, and I'm happy to take any questions. Yes?
I just want to say, last May when I first met you, I remember you sitting me down and saying, do not Google at all, anything. And I really took that to heart, and I appreciate it, because I do not Google anything. And it just gives me hope, you know, that every day there's new research coming out. So I just appreciate you saying that. Because it is so easy to get online and just see awful horror stories. So you telling me that has been.
Right, so then, and I didn't put this in a slide, but people will tell me, and I have to keep remembering the right fingers, we are now up to 14 FDA-approved drugs for stage 3 or stage 4 metastatic melanoma patients, right? 14. I'm not saying everyone's eligible for all of them. 14, and if my math serves, that's 14 years, okay? Other questions, comments? Yes?
Has the current political situation affected cancer research?
Yeah, so this is a hard one, right? So it depends how you're funded, right? So, and it depends on what Washington wants to fund. So I have a friend whose wife works in long COVID. They got word 10 days ago, all long COVID projects are being funded because this is a national problem and that we're at the cutting edge of trying to help figure out what to do for those people. We haven't heard any word yet of where they're gonna dice it up at UNC for cancer. So I think your point's very well taken. I just don't know where that's going. Fast forward to me, I'm 99% philanthropy funded. So I don't have any worry. In fact, I have to tell my research associates to relax because I'm in no danger of my funding being pulled because of how different I am in the funding. So I think it's an entirely fair question. I think it's dynamic, and I don't know where it's gonna come down, and I don't know where the whole indirect, and so for those of you that may not realize, the whole buzz about the academic medical centers being bloated is because of the indirect costs. Well, the indirect costs pay for the toilet paper, pay for the lights, pay for the janitorial services, pay for people that aren't in the grants. And so it's hard sometimes for John Q. Public to look at Duke is at 61%, UNC is at 55%. Well, that's a lot of people to lay off if the indirects go away completely. So wherever that is, so hopefully that's not too long-winded answer, but gives you more of a how this is shaping up, and it's literally a week-by-week thing, okay? Yep.
On the new therapy that UNC was the first to administer successfully
In these two states.
in these two states.
Yeah, I just want to be careful about that because other people have done it elsewhere, but I'm very proud, and we are very proud that we were the first in North Carolina, South Carolina.
And you should be. How is that therapy effective for brain mets, or is it?
We don't know yet. And the problem is that you might be able to get a patient on with brain mets, but the patient with brain mets has so many other issues that you really have to stabilize the brain mets before you're going to put someone into lymphodepletion and give back TIL cells. So totally fair question. I don't think any of us are ready to answer that yet for brain mets that aren't stable yet. Okay?
When do you think we would get there, or
Where I think that's why we have Brent Hanks in the room, that's why we have Sergio Moscos, that we're trying, right? Because if we're honest about it, that 51%, the overwhelming majority that takes the 51% are brain mets. The other are liver mets. So not that other stuff can't do it, but brain mets and liver mets dominate that 51%. Anything else? Paul, have I covered what you wanted? Thanks, Paul. Trish, we good? Oh, that was a lovely.